shoulder injuries can occur through what are called micro-traumatic causes, like playing tennis and swinging thousands and thousands of times, or serving thousands of times, or macro trauma, like a big trauma, like we fall on our shoulder really hard and we damage it, or what we call fouche injury, or fall in an outstretched hand. So different types of mechanisms of injury will affect different areas. So if we were to fall on our shoulder very abruptly, boom, and hit that area, or fall in an outstretched hand, we can affect everything. But we also have to take a look at the major joint that's usually forgotten with the shoulder, which is the acromioclavicular joint. And that is usually destabilized through ligamentous attachment. We also want to look at, with other injuries, micro or macro, the rotator cuff muscles, the four muscles, as I was discussing before in the mapping video, and then the labrum. The labrum itself will tend to have two common types of tears. There are more, but the two common ones are a slap tear, or a superior labral anterior posterior tear, or a Bankart lesion. A Bankart lesion is when we dislocate the shoulder, the anterior inferior labrum will tear, or reverse Bankart, when it goes backward, it could take out the posterior labrum. In these cases, you're going to learn this through history and through the examination, and you're certainly going to see these on an MRI. Are they all requiring surgery? No. Many times the body can heal in the right environment. Shockwave creates new blood supply in that area, recruits stem cells. It not only cuts pain and inflammation, which is wonderful, and the patients love it, but we're looking for that longer-term regenerative correction phase, and that's why it works so well. So in the case of a slap tear, we are going to be on the front side of the shoulder, and I would instruct the patient to externally rotate, because I'm going to follow that bicep tendon up the arm into the transverse humeral ligament, where the bicep tendon is going underneath of this, and then angling it up into the labrum itself, which we can do with an upward movement or go on top, back, and forth. In the case where we have the AC joint involved, through falling on it, or we test that to have a problem, or it shows up as a sprain strain on the MRI, we can come simply down straight onto the acromion and work our way around that in a circular pattern, looking for feedback from the patient or an apprehension sign. Sometimes the patient may not actually say, ouch, that really hurts, but you see them grimace, or it hurts, or they pull away. That's also telling us that they're feeling it a lot, and we want to make sure we treat the area, but we're doing it with appropriate protocols and appropriate energy level. The rotator cuff, the most common rotator cuff muscle injury, is the supraspinatus. And that muscle brings the arm out to the side, and it attaches right over here on the lateral side of the glenohumeral joint. And we can work up and down in that area a little bit. If we go a little bit posterior to that, we're into the infraspinatus. We have the spine of the scapula. Right below that is the infraspinatus, and back and down a little more, the teres minor. To get to the subscapularis muscle, which is the internal muscle, we'd have to have the arm up and out and get underneath. But in most cases, luckily, that muscle doesn't have the injury that the other three will tend to have. So again, if I want to hit the rotator cuff, teres minor, infraspinatus, supraspinatus, bicep tendon in the front, transverse humeral ligament, into the slap tear lesion up in this area. The Bankart lesion is inferior. We want to come up and into the armpit region to hit the anterior inferior. If we want to get more of a reverse Bankart, we could move the arm up and out and come in through the posterior capsule in this direction, up and down through here, and a little bit back and forth to hit a posterior labral problem.